There's a symptom that wrecks sleep for a huge percentage of postmenopausal women, and almost nobody talks about it in a menopause context. It's not hot flashes, it's not night sweats, it's getting up to pee, sometimes 2, 3 times a night. And it turns out estrogen has everything to do with it. That's where we're starting today.
Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host, Nikki, who handles the headlines. Take it away, Nikki.
Thanks, Tony. We've got a good one today. 3 symptoms, all of them underexplained, all of them real, and none of them the ones that get the most airtime. We're starting with something so mundane that most women never think to bring it up with their doctor, which is exactly the problem. Nocturia, waking up in the middle of the night to urinate. Once, twice, sometimes 3 times. The NAMS journal, that's the official journal of the North American Menopause Society, just published a practice pearl on this, and it lays out something that deserves more attention than it gets. A practice pearl, for anyone unfamiliar, is a clinician-facing summary. It's the kind of thing a doctor reads to get up to speed on managing a condition. The fact that NAMS published one on Nocturia in postmenopausal women is actually notable because it signals that the medical community is treating this as a distinct menopause-related condition, not just a side effect of getting older or drinking too much water before bed. Here's what the research shows. Estrogen isn't just a reproductive hormone. It has receptors throughout the urinary tract, the bladder, the urethra, the pelvic floor. When estrogen drops, those tissues change. The bladder becomes less elastic. The urethra loses some of its tone. The pelvic floor weakens. Bladder capacity decreases. And separately, because this is multifactorial, not one clean mechanism, the body's ability to concentrate urine at night also shifts. There's a hormone called antidiuretic hormone, or ADH, that helps your kidneys hold onto water overnight, so you don't have to get up. Estrogen influences the rhythm of ADH production. Lower estrogen can disrupt that rhythm, which means more urine being produced during the hours you're trying to sleep. On top of that, the paper covers the psychosocial layer. Anxiety and sleep disruption feed the cycle. You're already waking from hot flashes or night sweats, and then the bladder is an additional trigger pulling you out of sleep. The two problems amplify each other. My position on this one is direct. Nocturia belongs in the standard list of menopause symptoms that gets discussed at midlife appointments. Not as an afterthought, not as a geriatric concern. It's not just something that happens to older people. It's something that happens to postmenopausal women specifically, with a specific hormonal mechanism. And there are management options. Pelvic floor physical therapy has solid evidence behind it. Genitourinary syndrome of menopause, GSM, responds to local estrogen therapy in many women. Behavioural changes around fluid timing and caffeine actually do something. None of that gets surfaced if no one ever names the symptom. If you've been blaming yourself for this, cutting off fluids at 6 p.m, setting an alarm to avoid the frustration of waking up anyway, you are not managing a personal failing. There's physiology here. Worth taking to your doctor and being specific about it. Completely different anatomy, entirely different stakes. There's a new paper on PubMed published just this past weekend, June 22nd, on coronary microvascular dysfunction in menopausal women. And this one I want to slow down on, because the gap between how significant this condition is and how often it gets caught is genuinely frustrating to read about. Coronary microvascular dysfunction, CMD, is a condition where the tiny blood vessels that supply the heart muscle aren't dilating properly. not the large coronary arteries that show up on a standard angiogram. The small ones, the microvasculature. And estrogen, it turns out, plays a role in keeping those vessels responsive and functional. What this means clinically, a woman in perimenopause or postmenopause can have real cardiac symptoms: chest pain, shortness of breath, exercise intolerance, fatigue, and go through a standard cardiac workup and have it come back normal. No blockages found, normal stress test, and the conclusion too often becomes it's anxiety, it's stress, it's deconditioning. Come back if it gets worse. CMD doesn't show up on a standard angiogram because the problem isn't in the large vessels. You need different testing, coronary flow reserve testing, for example, to see it. And many general cardiology workups don't include that by default. The research on this has been building for years, but the 2026 paper reinforces what the evidence has been pointing toward. Estrogen loss is a cardiovascular risk factor in ways that go well beyond cholesterol and blood pressure. The microvascular system is one of the mechanisms. Women who present with chest pain after menopause and get sent home with a clean angiogram deserve the conversation about whether CMD testing is appropriate, not just reassurance that the big vessels look fine. This is the kind of evidence your doctor would look at on a tool like Open Evidence. It's not fringe research, it's peer-reviewed and increasingly part of the cardiovascular literature on women's health. The problem isn't the evidence. The problem is the translation into clinical practice, which lags by years. If you've had atypical chest pain, meaning chest pain that doesn't fit the classic elephant on your chest pattern, maybe more of a pressure, or pain during exertion that stops when you rest, and your cardiac workup came back normal, CMD is a legitimate question to ask. Specifically ask. Don't let normal angiogram be the end of the conversation. The third thing I want to get into is from an episode of Dr. Mary Claire Haver's podcast, Unpaused, where she sat down with Dr. Zachary Rubin. He's a double board certified allergist and immunologist, also a New York Times bestselling author, to talk about mast cells, histamine, and perimenopause. I'm flagging this not as peer-reviewed research, but as a genuinely useful explainer on a connection that the clinical literature does support, even if it's not yet in mainstream menopause conversations. So, mast cells are immune cells. They live in your tissues, skin, gut, lungs, brain. They're part of your first-line immune response, and one of the things they release when activated is histamine. Histamine is what causes the classic allergic reaction symptoms: itching, flushing, runny nose, hives. It also does things people don't associate with allergy. It affects gut motility, it crosses into the brain, and it's involved in anxiety responses. Here's the estrogen connection, and this is the part that tends to produce the "oh, that's why" moment. Estrogen has a complex bidirectional relationship with mast cells. Higher estrogen can prime mast cells to be more reactive. But the volatility of estrogen in perimenopause, not just the drop, but the wild swings up and down before it settles, appears to destabilize mast cells in ways that can increase histamine release unpredictably. What that looks like in practice: a woman in perimenopause who suddenly develops what feels like new onset allergies, or starts flushing for reasons that don't seem to be hot flashes exactly, or notices that certain foods, wine, aged cheese, fermented things, start causing reactions they never caused before, or anxiety that's hard to distinguish from a physical allergic response because histamine genuinely does activate the nervous system. Mast cell activation syndrome, or MCAS, is a diagnosis at the more severe end of this spectrum. But the broader estrogen-histamine axis affects women well below the threshold of a formal MCAS diagnosis. What I appreciate about the Haver-Rubin conversation is that it takes the symptoms seriously without overclaiming. Dr. Rubin is careful about where the evidence is solid versus where it's preliminary. That's the right approach. This isn't a fully mapped system. The research is still developing, but the clinical picture is coherent enough that if you're in perimenopause and suddenly reacting to foods or environments you never had trouble with, and nobody has an explanation, this connection is worth knowing about and worth raising with an allergist who's aware of the hormonal angle. The frustrating part is that mast cell expertise and menopause expertise rarely live in the same office. You might see an allergist who's excellent but hasn't thought much about how estrogen swings affect their female patients. You might see a menopause specialist who hasn't gone deep on the histamine connection. Finding someone who sits at that intersection takes work. But at least knowing this connection exists means you can walk into the appointment and direct the conversation.
Thanks for listening to Hot Flasher. We're back tomorrow with more, so don't forget to subscribe. See you tomorrow.